Okay, I guess we're starting almost on time. All right, well, I'm John Pandolfino, and this is my co-host, Shobna Bhatia, who is a dear friend and colleague who I've worked with for many years. And we're tasked with chairing the Chicago 4 and Frontiers of Esophageal Motility Disorders, Part 2. And our first talk is going to be on EGJ Outflow Obstruction, how to separate physiologic from pathologic, from Kristle Lynch from Pennsylvania.
Hi, good afternoon, everyone. I'm Kristle Lynch.
Already up.
And thank you.
You're quick. I was like, yeah.
And I'm efficient.
Stealthy.
Thank you to the organizers for inviting me, and this conference has been wonderful. I've been tasked with the most dynamic and most exciting motility disorder, so I hope that you learned something from this talk. The title of my talk today is EGJ Outflow Obstruction, How to Separate Physiologic from Pathologic. The disclosures are here. So today we will define conclusive EGJ outflow obstruction. We will understand the nuances of assessment of LES dysfunction and also develop a therapeutic approach to EGJ outflow obstruction. So we'll start with the case. I had a 35-year-old obese gentleman with asthma who presented with heartburn and intermittent dysphagia to solids, no weight loss, no regurgitation, no food impaction, and his PCP, his primary doctor, had trialed him on pantoprazole for 2 weeks. And there was some partial improvement, but the PCP ordered a barium esophagram and upper endoscopy. So you can see just a screenshot from the barium swallow here. Normal caliber esophagus. The read stated it emptied normally. There's a small hiatal hernia. And the upper endoscopy, we don't really see any evidence of EOE or other motility disorders, and the biopsies were normal, and the small hiatal hernia was again noted. So they ordered an esophageal manometry. And so this is just one representative shot of this, but the read stated 100% intact peristalsis with a normal DCI and distal latency, and the median IRP was 18.1 supine, 15.6 upright, and this was concerning for EGJ outflow obstruction. So the patient was referred to GI. So does this patient have findings that are concerning for true obstructive physiology at the GE junction? So here overall, we have a case of a patient with predominantly heartburn, intermittent dysphagia, no red flag signs, and overall pretty unconcerning testing. So I think we have a low suspicion for a significant motility disorder, largely being achalasia. So what can cause the elevated IRP? So here you'll see on the left a mimicked hiatal hernia sac. And you see that the manometry catheter is angulated. And at sensor 30, you see a pressurization on the manometry. And there's a representative swallow with the IRP at 16. But once the catheter is straightened, you see the pressurization disappear, and the IRP normalizes to 9. So that's one example of a hiatal hernia causing an elevated IRP. Here you can see a different example of a patient with an IRP of 20, but when you look at the bolus flow, you see it going down nicely through the GE junction and then refluxing back upwards, giving you a clinical suspicion not for motility disorder, but more for a hiatal hernia. There are other structural causes that can cause EGJ outflow obstruction, such as a ring. There are inflammatory causes, such as EOE, which also can cause structural and fibrotic changes. Post-surgical causes, we know that patients post-op, we really can't apply them perfectly to the Chicago 4, but that's something to keep in mind, and as well as malignancy and medications. So this is an example of a patient who had a manometry read with EGJ outflow obstruction when the patient was on opioid treatment. And when you take the same patient off of therapy, the IRP normalizes. So there's many secondary causes for EGJ outflow obstruction, many of which are listed here. So what about when we don't have any of these and we have effectively ruled these out in the patient? That is primary or functional EGJ outflow obstruction, and what we're concerned for at that point is evolving early or a variant of achalasia. So the Chicago classification 4, as you've heard from the previous speakers, has more stringent criteria in order to give us an algorithm for what could be clinically significant EGJ outflow obstruction. So more stringent manometric criteria, relevant symptoms, as well as abnormal testing that's not manometry. So regarding the manometric criteria, we talked about this during the prior lectures of the elevated IRP in multiple positions plus the supine swallows, at least 20% with the elevated intrabolus pressure. Additionally, remember that the Chicago 4 recommends describing the peristaltic patterns when you see EGJ outflow obstruction manometrically, because we know that when patients don't have evidence of disordered peristalsis, perhaps that's less clinically significant. And observational studies have shown us this. As for other manometric aspects, we've heard multiple times today about provocative esophageal testing. So regarding the rapid drink challenge, we know that typically patients will have either physiologic LES inhibition or impaired LES inhibition when you're looking at the rapid drink challenge in regards to EGJ outflow obstruction. So this is not a manometric criteria, but this can give you supportive information when you're trying to figure out the patient's physiology at the EGJ. Solid test meal has also been touched upon today. Solid swallows, normally the IRP is less than 25. And with a solid test meal, evidence of an elevated IRP or PEP can be indicative of obstruction. So again, supportive testing. So I'd pause here to say when solely manometric criteria are met, a diagnosis of EGJ outflow obstruction is considered inconclusive. So next we'll move on towards relevant symptoms. So when you look at the symptoms that patients presented with EGJ outflow obstruction via the Chicago 3, they're really across the board here. So dysphagia and chest pain, as well as regurgitation, reflux, and then an assortment of everything from hoarse voice to hiccups to cough. And so per the Chicago 4, patients need to have either dysphagia and or chest pain in order to meet symptomatic criteria for potentially clinically significant EGJ outflow obstruction. And lastly, we'll touch on abnormal time-barium esophagram or FLIP. So we know that time-barium esophagram is very helpful in distinguishing LES dysfunction in achalasia. And there's many criteria that have been used when you're looking at various studies. So we know that a 5-centimeter column at 5 minutes is certainly concerning, as well as tablet impaction. But the studies are somewhat heterogeneous. Some studies reporting 1-centimeter column at 5 minutes, any column at 1 minute, sort of describing the appearance via a bird's beak or a corkscrew. Also even looking at the dilated esophagus, the width of the esophagus, or even the surface area. There are a couple investigations that I'll touch on. Blonsky and colleagues noted that a time-barium esophagram did not help differentiate patients with EGJ outflow obstruction from non-achalasia patients. However, the patients who had EGJ outflow obstruction, who had obstruction on time-barium esophagram, many of those patients had pneumatic dilation, and the majority of patients had symptom improvement. There was another study by Triggs and colleagues of 155 patients with EGJ outflow obstruction on manometry, 30% of which had radiographic EGJ outflow obstruction, and an upright IRP in patients with radiographic EGJ outflow obstruction or symptoms of dysphagia was higher than those without those features. And so you see here an example of a patient with an elevated supine IRP, but a normal upright IRP. And from the screenshot of the barium swallow, you can see that the liquid and the tablet are passing normally. Here is a patient with an elevated supine and upright IRP, and you can indeed see that barium tablet impaction. And similarly, a patient with an elevated supine and upright IRP with a significant column at 5 minutes. There was a study of 47 EGJ outflow obstruction patients, 25 of whom underwent TBE, and 3 eventually developed achalasia. And they were evaluated retrospectively for any barium retention, and this was not shown to be predictive of treatment response or progression of EGJ outflow obstruction patients. So, no test really is perfect, but we need to take what pieces of information we have and apply them clinically to our patient. So next we'll move on towards FLIP. I know everyone is familiar with the endoluminal functional lumen imaging probe. This is an FDA device approved to measure pressure and cross-sectional dimensions in the esophagus, pylorus, and anal sphincters. And we're looking at the desensibility index, or the cross-sectional area over balloon pressure. I know that several sessions will touch a little bit more on this, but just to remind you of the FLIP protocol, using the 16-centimeter FLIP, positioning the catheter with 1 to 2 centimeters in the stomach, and we'll do stepwise volumetric filling, pausing really at 50, 60, and 70 milliliters for 60 seconds each, and looking, especially in these patients, at the EGJ DI and the max EGJ diameter, as well as the contractile response pattern. And so when we're looking at the EGJ opening, in green, you'll see the normal EGJ opening with a DI of at least 2 and the diameter of at least 16. And then in red, the reduced EGJ opening with a DI less than 2 and a max EGJ diameter, typically less than 12. So here are some examples of 2 very different patients who are undergoing flip. And on the left, you can see these repetitive contractions. They're antegrade. And if you'll notice at the bottom, right where the GE junction is, it certainly appears to be opening. And indeed, I know it's hard to see the numbers, but that was considered a normal EGJ opening. And on the right, you see no change. We see no evidence of contractility, and the EGJ DI was indeed low, concerning for reduced EGJ opening. So work by the authors in the room in 2021 of 722 patients who underwent manometry and flip. You'll notice that of the 210 patients with reduced EGJ opening, 90% of those patients had EGJ outflow obstruction or achalasia. And of the 187 patients with normal EGJ opening, only 1 patient ultimately was found to have EGJ outflow obstruction or achalasia. So it's easy to see how you could sort of apply this to these patients. I will say that this is working in the contractile response pattern in those results. So on the left are the categories of the contractile response pattern, and on the top is the dynamics of the EGJ opening. So when you look at the bottom right group, those patients had absent contractile response pattern and reduced EGJ opening. And the grand majority of these patients had achalasia or EGJ outflow obstruction. But if you look at the patients who had a normal contractile response pattern and normal EGJ opening, none of them had achalasia or EGJ outflow obstruction. I'll touch on a study by Beveridge and colleagues of 20 EGJ outflow obstruction patients who underwent flip. And if the DI was low, Botox was injected. And the mean Eckhart score did improve in patients with an abnormal over normal flip, but we had no sham procedure. And the low DI was associated with delayed bolus transit and PEP on RDC. And then a larger retrospective study of 139 patients with inconclusive EGJ outflow obstruction. This looked at the flip findings and the response to therapy, whether they were achalasia type treatments, so that's on the left with pneumatic dilation, myotomy, and Botox, or non-achalasia type therapy, which is on the right. And it's sort of on the y-axis, you can see the Eckhart score. And you can see in the gold box, those are the patients with conclusive EGJ outflow obstruction who underwent achalasia-type therapies. And you can see the Eckhart scores certainly look much lower. And on the right, the patients with conclusive EGJ outflow obstruction who underwent non-achalasia-type treatments who don't appear to respond as well. Indeed, the study showed us that abnormal flip patients responded better via Eckhart to achalasia-type therapies at 77% versus non-achalasia-type therapies at 0%. So we'll pause here to note that a barium column of at least 5 centimeters at 5 minutes or tablet retention is certainly concerning for functional EGJ outflow obstruction, but there's other criteria that various studies have used as well. Reduced EGJ opening on flips supports a diagnosis of significant EGJ outflow obstruction, and normal EGJ opening with a normal contractile pattern really overall decreases our suspicion for a significant motility disorder or early variant achalasia. Other things that have been proposed for obstructive evaluation include pharmacologic provocation as well as cross-sectional imaging. And we've heard about pharmacologic provocation earlier today, touching on amyl nitrate. And we'll see sort of little pressure change in control patients, but at least a 10 millimeter IRP reduction seen in patients with smooth muscle inhibitory dysfunction. And so you can see in A here, a patient with functional EGJ outflow obstruction, and in B, patient with secondary EGJ outflow obstruction. Cholecystokinin has been discussed as well. So we know this typically induces esophageal shortening and incomplete EGJ relaxation. And you see sort of this marked paradoxical contraction of the LES when inhibitory dysfunction is present, as you can see here. Cross-sectional imaging in the US, in studies with the Chicago 3 have not shown to be necessarily high yield. So liberal use is not recommended. But in specific cases with highly concerning features or rapid weight loss, it certainly may be applicable to your patient. So we'll pause here to say that comprehensive evaluation for obstruction of the GEJ is key, but no single testing modality is flawless. So where does that put us with our EGJ outflow obstruction algorithm? So if the patient has an elevated median IRP in multiple positions and some intact peristalsis, then we evaluate for elevated intrabolus pressure. If that is present of at least 20%, then we look towards their symptoms. And if there's dysphagia or chest pain, then we will move on towards abnormal time-bearing esophagram or endoflip. And if that's present, the patient is thought to have conclusive EGJ outflow obstruction. There are certain parts along here where you may not have the criteria, and it depends sort of where it is. If there's no elevated intrabolus pressure or no dysphagia or chest pain, that is actually not considered EGJ outflow obstruction. If you get all the way to the non-manometric testing and there's not an abnormal TBE or flip, that is inconclusive EGJ outflow obstruction. And that can be tricky on a practical level. You have these patients with symptoms, and they said, I had this diagnosis on manometry. It's not unreasonable to consider monitoring and repeating workup and seeing if there's anything that changes. So where do we stand with principles of therapy? So if conclusive EGJ outflow obstruction is not diagnosed, we are not pursuing LAS targeting therapies. If the symptoms persist over time, we can consider repeat testing. But if inconclusive EGJ outflow obstruction, earlier variant achalasia, it's not guaranteed, right? We have to look at the adjuvant testing, the data, the clinical picture for the appropriateness of LAS dysfunction. So, a sort of graded approach has been proposed, considering off-label use of muscle relaxants, and even considering a typical balloon dilation to 20 to ensure that there wasn't a subtle stricture or anything like that before pursuing achalasia therapy. So this has been proposed, but if your suspicion is high, a trial of botulinum toxin injection is not unreasonable. And there are small series on carefully selected patients with EGJ outflow obstruction that have revealed good outcomes with pneumatic dilation and various types of myotomy. But just keep in mind, as Dusty has said before me, that definitive LAS therapy cannot be reversed. So our summary and pearls today: secondary causes of IRP elevation should always be considered. An isolated manometric diagnosis of EGJ outflow obstruction is inconclusive. A comprehensive evaluation, including symptom analysis and complementary testing, is necessary to identify conclusive EGJ outflow obstruction. And even with conclusive EGJ outflow obstruction, early achalasia is not certain. So a comprehensive evaluation of all of the data should really be performed. Thank you.
Thank you very much. I think we have time for one or two questions. So you're stealthily trying to get off the stage, too.
Yes.
That's how I am.
Questions?
Yes, Prakash.
Prakash. I'll introduce the next one.
My question is, why do you want to call it functional EGJ outflow obstruction? So I'm just coming from Chicago, where we were beat up on the use of the word functional. Should we be using some other term here?
I do not like using that term, and I'm using that term because this is what the studies are showing us. So I feel like that term has been used, but I do agree that that actually can be quite confusing, and I think it would make sense to actually move away from that, and really calling it primary or idiopathic would also make sense. I also think it's confusing that there are so many different terms for what we're trying to describe, but it's important to separate out the secondary. So I think at least, there has to be some sort of descriptive word before it. But perhaps that can be discussed at the next Chicago meeting. Classification. Add it to the list.
So I think it was a very good talk. But just a small suggestion. Would you look at the symptoms first or the manometric diagnosis first when you're looking at EGGO? I thought
Right.
symptoms would come much higher on the list.
Right.
And if the patient didn't have dysphagia or chest pain, there was really nothing much that you could, if you looked at the
Yeah.
EGG obstruction. Yep.
Certainly, it's
Okay.
hard. At our center, we do, have outside referrals, and patients have the manometry before their pH impedance. So we have a variety of, diagnoses that come before, we have sort of screened to have the manometry. We don't screen at our center prior to doing the manometry, but we've certainly seen it in many patients prior to advanced pH testing as well, without these symptoms.
Okay, we have to move on to the next talk, but just for a poll, how many people in the audience actually use provocative pharmacologic manipulation with CCK or amyl nitrite? 0 people. I wonder if we should continue to talk about that when no one's using it.
Peter gets to talk about it tomorrow. So.
Yes, so interesting. Yeah. All right, well, another stealthy person up here already. So I'd like to introduce Dr. Joan Chen from Michigan, who's going to talk to us about hypercontractile and spastic motor disorders.
Thank you so much. Thank you so much for the invitation. I'm really honored to be here, to be in this gorgeous setting and speaking amongst the world experts. So I have been tasked to talk about hypercontractile and spastic disorders today. So these are my quick disclosure. A quick outline, I'm going to be talking a little bit about what we know about the pathophysiology of hypercontractile and spastic disorders. We'll talk about important conditions associated with spastic esophageal disorders, and we'll go over some of the diagnoses, conclusive and conclusive, based on Chicago Classification version 4.0, and then we'll talk about management options, and I think importantly, talking about decisions to treat versus to leave patients alone and observe, and then some new insights from last week's DDW. So what we're talking about today are spastic disorders. These are conditions where there's peristaltic hyperactivity resulting in contractions that are either too strong or too fast, leading to esophageal symptoms. And those symptoms are usually non-cardiac chest pain or dysphagia. So the specific conditions include hypercontractile esophagus, diffuse esophageal or distal esophageal spasm, and spastic or type 3 achalasia. But I'm going to focus my talk on hypercontractile esophagus and distal esophageal spasm because the other conditions have been talked about today. So what causes spastic disorders? We think a lot about abnormal inhibition, leading to a lack of latency in distal esophagus, because it's thought to play a large role in spastic disorders. And this concept of latency was suggested by Behar and Biancani, as demonstrated in this figure here, where the inhibition from normal swallowing triggering the distal esophagus to delay in contraction relative to the proximal esophagus that you see in the open circle on the graph there is lost in patients with spastic disorders. And you really see this kind of simultaneous and premature contraction in the distal esophagus. And this can be seen in modern manometry by provocation maneuvers like multiple rapid swallows and rapid drink challenge that we've talked about on multiple talks so far. Some of the other etiologies for spastic disorders might include also cholinergic hyperexcitation, and we frequently think about this in hypercontractile esophagus. That can lead to exaggerated smooth muscle contraction. So this can be seen on this elegant study recently that showed that hypercontraction can be obliterated by a cholinergic blockade such as atropine. We also have recently started talking about the possible roles of eosinophilic involvement, and typically this involves the muscularis layer, as seen in this example here, where you only see a few scattered eosinophils in the epithelial layer, but in the muscle layer you see kind of dense eosinophils indicating esophageal eosinophilic myositis. But the exact roles of eosinophils in causing spastic disorders is currently unclear. Another potential etiology for spastic disorders is, again, this was touched upon earlier today, increase in muscle thickness. And this was demonstrated in this study showing that at different levels of the esophagus in patients with nutcracker esophagus or distal esophageal spasm, the muscle layer is thickened, and the thickness is seen in the circular muscle layer as well as the longitudinal muscle layer. And it's felt that the hypertrophic muscularis propria is associated with reduction in the esophageal compliance and decrease in esophageal ability to accommodate bolus, and therefore causing dysphagia. So a few important associations, conditions that are associated with hypercontractile esophagus and spasm, one of which is reflux. Reflux is seen in very high prevalences in these conditions. In a couple of studies, nearly half the patients or more had concurrent gastroesophageal reflux disease. However, the response rate to proton pump inhibitor has been shown to be quite variable, such as this one study showing that whether patients are on proton pump inhibitor or not, their symptoms did not change when they have underlying hypercontractile esophagus or dysphagia or spasm. So along with GERD and rarely eosinophilic esophagitis, we also, it's been pointed out several times that opiate use is associated with spastic esophageal disorder, as seen here. And distal esophageal spasm and jackhammer esophagus were among the top 3 most common esophageal dysmotility diagnoses seen in patients with opiate-associated or induced esophageal dysfunction. And not all opiates, though, affect esophageal motility the same. This is a recent study by Patel et al. That showed the differential association of spastic disorders and various opiates, and almost no association of partial agonists, such as tramadol, with the spastic disorders. And we can see also that patient symptoms improved over years if they were no longer on opiates, versus if they were continued on the opiates, as seen in the blue line. So this is powerful evidence in support of our typical recommendation to patients that are on chronic opiates to perhaps switch to a medication such as tramadol, or if they cannot stop the medication at all. So I'm going to really quickly go over the diagnosis of hypercontractile esophagus because we've kind of talked about the evolution with the recent Chicago classification. But just remembering where we started from, hypercontractile esophagus initially on conventional manometry was defined based on 2 standard deviation above the mean of peristaltic amplitude, with 120 as the initial cutoff, and then it moved to 180 when the normative data changed. The diagnosis was made more stringent, increasing the cutoff to 220 millimeters of mercury. And then with high-resolution manometry, this translated to a mean distal contractile integral of 5,000. And then we further made it more stringent when this extreme phenotype of hypercontractility was described with DCI greater than 8,000, where there's prolonged and repetitive contraction that we call jackhammer esophagus. And it was further stricken to 20% of swallows with DCI greater than 8,000 in Chicago classification version 3.0. And then in the most recent iteration, the metametric criteria was kept in place, but this then further required clinical relevant symptoms of chest pain or dysphagia, in addition to metametric diagnosis, and also after exclusion of obstruction, spasm, achalasia, and opiate-related dysmotility. Similarly, distal esophageal spasm also has undergone an evolution in its definition. So initially defined as simultaneous contractions in greater than 10% of wet swallows with intermittent normal peristalsis. Then we use rapid contractions in 10% of wet swallows using the parameter contractile front velocity greater than 9 centimeters per second, with contractile amplitude greater than 30 millimeters of mercury. Then it was further changed to using distal latency as the primary parameter for diagnosis, because this was felt to be more clinically relevant and more specific for spasm. And the last iteration of Chicago classification, again, we had it required 20% or more swallows with distal latency less than 4.5 for a diagnosis. And that was kept in place again for with Chicago classification version 4.0. But again, we now require clinically relevant symptoms and only after rolling out opiate-related dysmotility. So what about the inconclusive diagnosis of hypercontractile esophagus and spasm? So these are where in the cases of hypercontractile esophagus, DCI is between 5,000 and 8,000. And in cases of diffuse distal esophageal spasm, premature, but low DCI, less than 450, or those with normal distal latency, but rapid contractile front velocity. So I've shown a couple of examples here. So as I mentioned, the contractile front velocity was found to be nonspecific or more nonspecific for a major motility abnormality, and this was demonstrated from a study by Dr. Pandolfino and colleagues, whereas the distal latency nearly uniformly had identified patients with dysphagia and major motility disorders, including achalasia and spasm. And this is why we have moved on from contractile front velocity to using distal latency for diagnosis. In these inconclusive diagnoses, we consider adjunct testing in addition to investigations or repeating manometry for patients with persistent symptoms after we have ruled out confounding circumstances. So these are some examples of testing that can be done in patients with inconclusive studies. And that includes, rapid drink challenge provocation maneuvers and using barium esophagram, as well as now considering using functional lumen imaging probe. So in this one example, 3 patients with hypercontractile esophagus did show very different patterns on flip, with the first patient showing a pattern that is close to achalasia, where there's no contractile response and reduced EGJ opening, whereas in the second patient, we see slow rack pattern or repetitive integrate contraction, but some lumen occluding contractions. In the third patients, we see sustained occluding contractions. And so, but on manometry, all 3 of these patients show hypercontractility. So you've seen this slide a couple times already today. So another possible way to help identify patients with clinically relevant diagnosis is to use solid test meals. And solid test meal has been shown to increase the sensitivity of diagnosis. And so more patients, as you can see here, were diagnosed with a spasm on solid test meal as compared to single wet swallows. And there are also a higher percentage of patients that reported reproduction of symptoms during solid test meals comparing to single wet swallows. So now we've come a long way, obviously, with spastic disorders, but why is it that our knowledge on the disease progression and treatment is still quite limited? And there are several reasons, but number one is that this is a very rare diagnosis, as we all know, especially with the more stringent criteria for diagnosis. It is also a very heterogeneous diagnosis. Patients present with a wide range of symptoms. Oftentimes it's dysphagia, chest pain, regurgitation, heartburn, but some patients present with no symptoms at all. There are also many metametric phenotypes. As seen in the pictures here, we see single peak versus multi-peak contractions. We see LES dependent versus LES independent hypercontractility. And the diagnoses are also oftentimes associated with other conditions, like I mentioned, GERD and opiate-induced dysmotility, making it difficult to diagnose and to manage a lot of these patients. But these are what we have as the treatment option currently, and I'll just say that primarily the goal of treatment is to reduce symptoms, and sometimes it is also to reduce contractile vigor and speed. But the treatment options might include observation while we treat the overlapping conditions. It could be pharmacologic, including some of the antihypertensives, antispasmodics, or neuromodulators. I've also included botulinum toxin injection here, and I'll show a quick slide on that. But more recently, the myotomy for these non-achalasia motility disorders have gained traction, so I'll show a little bit of data here. So these are the pharmacologic options that are frequently considered for hypercontractile and spastic disorders. The use of these medications are mostly based on small clinical trials in patients with non-cardiac chest pain or nutcracker esophagus, and are results of smaller case series. And in patients that have primarily chest pain or a high suspicion for visceral hypersensitivity, some of these neuromodulators actually might make more sense and be more effective in treating these patients. So botulinum toxin could be a treatment option for these patients. In one randomized controlled trial, botulinum toxin injection was shown to reduce symptoms of dysphagia in patients with spasm and nutcracker esophagus. However, in a different study using sham-controlled randomized trial, there was no difference in symptom improvement from baseline as seen in this figure here. So botulinum toxin injection may not be superior to sham in improving symptoms related to hypercontractile disorders. So what about POEM, peroral endoscopic myotomy? There have been a few studies now showing its efficacy in treating non-achalasia motility disorders, and this is one study that showed that in patients, they combined jackhammer esophagus, distal esophagospasm, nutcracker esophagus, and outflow obstruction, and at 3 months and 6 months, there is a fairly similar response rate in terms of patient-reported symptom response between the achalasia and the non-achalasia motility diagnoses. However, again, taking a step back, and this has been stressed prior to my talk, but myotomy results in elimination of distal contractions that is irreversible. So a decision to pursue myotomy in a condition where potentially a sizable portion of these patients will be asymptomatic or will have symptom improvement without treatment really should not be made lightly. So a couple of studies from the last week's DDW here. The first one is a study looking at LES preserving POEM. They performed POEM preserving the LES in patients with jackhammer esophagus and distal esophagospasm. And you can see that patient symptoms improved post-POEM up to 2 years, and only a small percentage of patients had esophagitis, 11% in their series. And the authors did conclude that LES sparing technique could be considered and might have fewer adverse events of GERD. Another study at DDW looked at the outcome of POEM performed on patients with spastic esophageal motility disorders on chronic opiates. So they retrospectively analyzed patients with distal esophagospasm and hypercontractility, EGJ outflow obstruction, and type 3 achalasia that had undergone POEM and showed a near 80% clinical success rate. However, when they stratified patient response by the amount of opiates that they're taking, they found that patients on higher dose of opiates chronically, 40 milligrams or morphine milligram equivalents or higher, the response rate, the percent of non-responders was higher in this population on high-dose opiates, even though there's no difference in post-POEM distensibility index on FLIP in these patients between the responders or non-responders. So one of the first questions that we encounter when we, after giving a diagnosis of hypercontractile esophagus or spastic disorder, is generally who should we treat or who should we observe, because we know that, like I said, a large portion of these patients will have clinical improvement without treatment. One thing to remember is that spastic disorders are generally considered benign, non-progressive, and may improve. So a couple of studies here. One is looking at questionnaire, the Demeester questionnaire on patients, in looking at the long-term outcome in these patients. And we can see that patients with diffuse esophagospasm and with nutcracker esophagus reported symptom improvement over time. And this is another study looking at, this study combined patients with hypercontractile esophagus and EGJ outflow obstruction, and you can see that symptom reduction over time was observed whether these patients received treatment or not. So specifically, 73% of patients with hypercontractile esophagus were asymptomatic at a mean 36-week follow-up without treatment. So who are the people that we should treat? I think careful patient selection is key. And, obviously those patients that have persistent symptoms, patients that have absent reflux or mechanical obstruction or opiate use or eosinophilic esophagitis at this point, that might be confounding the diagnosis. But there are also other certain phenotypes that we have seen on manometry that could be associated with a more severe disease. And these are patients with high DCI or multi-peak contractions, higher percent of premature contractions on those patients with spasm, possibly abnormal bolus clearance on impedance studies or FLIP, or abnormal FLIP. And all the while keeping in mind that there is a small population of these patients with spastic disorders that might progress to, in this case, type 3 achalasia. So this is my algorithm for managing patients with spastic disorders. So patients coming in with non-cardiac chest pain or dysphagia, after endoscopy rolling out a mechanical obstruction or eosinophilic esophagitis, and manometry off opiates, meeting Chicago classification version 4.0 for a conclusive diagnosis of hypercontractile esophagus or distal esophageal spasm. You might want to consider an empiric trial of proton pump inhibitor because of the high prevalence of GERD. And in those patients that don't have improvement or have negative reflux testing, then we might consider pharmacologic options, including neuromodulators or smooth muscle relaxants. And then in a lot of these people, if they have persistent symptoms, considering repeating manometry down the road, but only the select the select patients, you might consider endoscopic or surgical options. So overall, employing a less invasive to a more invasive treatment approach. So this is my last slide to kind of wrap up what we know and what we still need to learn. What we know is that these spastic disorders are rare, heterogeneous conditions. What we still need to know are the mechanisms behind symptom generation, because ultimately we want to treat patient symptoms. We know about the conclusive diagnosis using the latest Chicago classification, but we want to know more about the different phenotypes and how they might matter clinically in terms of treatment. And we also want to know how some of the supportive testing or provocation testing can help in some of the inconclusive cases. We know that spastic disorders can be associated with GERD and opiate-induced esophageal dysfunction. Are there other conditions such as eosinophilia that is also associated with these conditions? And then also strategies for treating the more difficult to treat opiate-induced esophageal dysfunction. We know that many of these patients will improve with time, but who and how long do we monitor them? So the natural history of spastic disorders need to be better teased out. There are currently a wide range of options, but how do we identify the patients that have a more severe disease phenotype or early type 3 achalasia phenotype? And also we need more treatment long-term outcome to understand how the treatments will affect patients down the road. And then POEM, being the newest kid on the block, it seems like a great solution, but what about what length of myotomy should we be performing, LES sparing like the DDW study had demonstrated, and then how do we prevent adverse events after POEM, such as reflux or blown out myotomy, like one of the presenters have talked about earlier. So that's all I have.
Thank you. Thank you, Joan. We just saw that we're a little out of time, so I'm going to ask only one question. I'll take the priority of the chair. And the chairman's purview. Yes, so one question is that you talked about patients on opioids taking a long time for their symptoms to disappear, even after the opioids were stopped. So why do you suggest that we stop the opioid before we do the manometry?
So
Symptoms take a long time, and do you think in 1 or 2 days of stopping opioids, the manometry is going to change?
yeah, I think that's a great question. And, the question is how long does it take for the opiate effect to be reduced? And I don't think we have the answer. I think for most patients, the most that I can get a patient to not take opiates before a manometry, generally 48 hours. The longer the better, though, right? And if they can not, continue to take it all together, it's better for them to be off the medication. Maybe if they can be off a month before manometry, then they can.
Then they don't need the
Then
manometry,
they don't,
probably.
right? They
Yes.
don't need it anymore. So, yeah.
Okay, thank you. So our next speaker is going to be Rami Sweis, and he's going to tell us about a topic that John actually doesn't like, that is ineffective motility. So,
I don't like the diagnosis of it.
oh, you don't like the diagnosis of ineffective motility, and that's why he's asked Rami to talk about it.
I think I agree with you guys. But anyway, let's see if this opens. In answer to the other question about opiates, I do the test on opiates because that's why they're presenting. They're presenting with symptoms on opiates. So you might as well do the test on opiates to see why.
Use the mic.
Yeah, okay.
Okay.
Anyway,
Thank you.
that's not my topic. Hold on, is this working? Yeah. Thank you so much for inviting me to speak today, Mark, and the organizing committee. I still can't believe it's 2015 since the last Ascona. It's so nice to see familiar friends and friendly faces in this beautiful setting. My task today is to talk about ineffective esophageal motility and aperistalsis. Conflicts of interest. Look, I'm a simple man. I don't do algorithms. So this is my cartoon of the Chicago classification. This is 3.0. It divided motility disorders into major and minor motility disorders. And I think that's excellent. I still use it in my reporting because it does make a difference to the way you define pathology. But Chicago 4.0 divided motility disorders into those of EGJ outflow, which you've heard about, and disorders of peristalsis, some of which you heard about, and now I'm going to talk about these two. So compared to 3.0, absent contraction is exactly the same. Nothing's changed. Absent peristalsis, it's exactly what it says on the tin. IEM, on the other hand, has been reduced to just the most significant, and that is the greater than 70% ineffective swallows or over 50% failed swallows. And that's important because it removes a lot of the FAF. Ineffective swallows are defined as peristaltic breaks that are greater than 5 centimeters. Weak contractions are a DCI of greater than 100 and less than 450, and failed peristalsis is less than DCI of less than 100. So we just mentioned DCI. DCI still applies. DCI of over 450 is normal. DCI of less than 100 is failed. DCI of between 100 and 450 is considered weak. And these are these ones are considered. Do you see my arrow? No, you don't see my arrow. These ones are.
Let me just speak closer to the mic.
Okay, so the ones on the left are considered to be the ineffective swallows. So we also have gotten rid of fragmented peristalsis. No longer is it used to designate as an independent designator. It's been incorporated into the IM definition. And we have defined IM into conclusive and inconclusive. Conclusive IM is greater than 70% ineffective swallows. Inconclusive is between 50 and 70%. It's kind of the gray area, like the Lyon consensus. So we need to do something else to define whether this is real or not. And most commonly, the way we do this is with provocative testing. So this study was very interesting. It showed that when you divide patients into conclusive and inconclusive IM compared to normal high-resolution manometry was more likely to be associated with higher risks of dysphagia. However, symptoms of heartburn, regurgitation symptoms did not differ between the groups. We know this from the old studies, from conventional manometry. Radu Tutuin showed us way back when that patients with ineffective esophageal motility were more likely to have ineffective bolus transport. We also know this. Sabine Roman and company showed us this very clearly, that the wider the break in the peristalsis, the more likely that incomplete bolus transport will occur. And now we also have a pictorial image of this. We can see this on impedance. We can see when breaks in peristalsis are wide, there's more likely risk of incomplete bolus transport, while smaller breaks, we can see that they're really irrelevant to this case. Now, the Chicago group have also showed us very nicely with a study that if you follow patients up who have what's considered minor motor disorders, over time, many of them have have spontaneous improvement or no symptoms at all. And the largest group of these are those with hypotensive motility or weak peristalsis. So, like in the previous talk, many of these patients, you just need to leave them alone and do nothing. So what are the implications? We don't know whether the poor motility leads to reflux or whether severe reflux leads to poor motility. There are no longitudinal studies looking at how patients progress between GERD and esophageal hypomotility. But we also know from Eduardo's, Severino's group and others that as you go up, down the reflux risk group, when you go from Barrett's esophagus when you go from endoscopy negative reflux disease to erosive esophagitis to Barrett's esophagus, the likelihood of ineffective esophageal motility, the likelihood of abnormal bolus transit tends to increase. And the ACG guidelines do suggest that anyone who is being investigated with a view to being considered for anti-reflux surgery should have manometry, primarily in order to exclude major motor disorders such as absent peristalsis, and those who have IEM should have some form of testing to assess whether or not they have contractile reserve. But the question is why? Because we also know that tailoring surgery hasn't shown, there's no evidence that tailoring your surgery depending on these results makes any difference, apart from with absent contractility, where it's more or less contraindicated. So provocative testing. Swallowing small volumes of fluid in the supine position doesn't really trigger symptoms. It's not really relevant to normal eating and drinking behavior. So we want to reproduce normal eating and drinking behavior. And there are lots of different ways of doing this. I'm not going to get into too much detail because I don't want to steal Santosh's thunder, but we can't talk about IM without bringing in some of this. And in fact, the technical review that we wrote did discuss how IM and aperistalsis does require the next step. 5 ml water swallows is really not enough. So there's lots of work that has been done on this, and Prakash Gewali and his group in St. Louis have done a lot of work on this, and so have others. In particular, MRS, looking at how the swallow is augmented after a series of small volumes of water, and using that as a ratio with the average DCI of small volume water swallows in sequence. And a DCI of greater than 1 is considered normal because you're augmenting the peristalsis following an MRS protocol. And he used this to also prove that those who have a ratio of less than 1 are more likely, not all, but more likely to have symptoms of dysphagia postoperatively. Would you use this these findings to limit someone from having anti-reflux surgery? Would you tailor your surgery according to these findings? I'm not sure, but this is an important and interesting finding. The group have also shown us very nicely here that if you take patients with IEM and you divide them into those with severe and non-severe, non-severe being 5 to 7 ineffective swallows, and severe being over 8 ineffective swallows, and divide those into those with and without contraction reserve. What you find is that those with non-severe IEM with contraction reserve are, and you look at the acid burden, they're very much similar to those of the normal high-resolution manometry group on the left. When you take those with non-severe IEM without contraction reserve, they are very similar to those with severe IEM in terms of acid exposure time. And those with severe IM, regardless of contraction reserve presence, are very similar to those with the absent contraction. So it does make a difference with regards to reflux burden. What about single solid swallows? I mean, that's very easy. You take swallow a piece of bread. And we know from our studies and other Mark's studies and other people that as you go from water swallows to solid swallows, distal contractile integral tends to increase. The contractile front velocity tends to slow down. Duration of swallow tends to prolong. We know this, and we see this repeatedly. And we know that when you look at patients with reflux, when compared to single water swallows, when you give solid swallows, the likelihood of patients who have an ineffective esophageal motility tends to be associated with preserved peristalsis and contraction reserve in those who are normal or those with endoscopy negative reflux disease, but not in those with erosive reflux disease. And you can see examples of this here. Endoscopy negative reflux disease, erosive reflux disease, though both of these have IAM patterns, when you give them solids, not uncommonly in the endoscopy negative reflux disease group, there is peristaltic reserve, but in erosive reflux disease, it is less likely. Similarly, we showed that in Barrett's esophagus, when you compare to water swallows, giving a solid swallow, you're more likely to induce a peristaltic contraction in endoscopy negative reflux disease, but less so with severe reflux such as Barrett's esophagus. So it's intuitive. What about eating? That's the most likely to reproduce your normal behavior. Now, in health, normally it's nice to give this talk before your meal so you can think about it while you're eating. When you're eating, you have 1 swallow, 2 swallows, 3 swallows, and then you feel the food going down, and that's normal. Not every swallow mechanism leads to a peristalsis, and that's what happens in health. While in severe reflux disease, that might not happen. You might have 1 swallow, 2 swallows, 3 swallows, nothing's happening, and then when the peristalsis occurs, it's ineffective, and it's then that you start to get the regurgitation occur. So Mark's group have validated the techniques of the provocative testing by performing 5 ml water swallows, 200 mils of water drunk freely, a meal in all comers. And out of 750 patients who were assessed, when compared to water swallows, the likelihood of an ineffective esophageal motility diagnosis reduced by more than a half, and the likelihood of an absent peristalsis reduced by 2/3. So we're making things more relevant by doing this. And of course, symptoms are more likely, many times over, compared to single water swallows. And we hear the criticism of with the solid swallows there isn't very much evidence of protocolization. Well, in fact, there is. The study does show in the same journal, Lancet Gastro, we have a Chicago-style classification of how to investigate and diagnose patients based on solid swallows and a meal. Now, when we're looking at 5 ml water swallows compared to solids and all that, we run the risk of overdiagnosis and underdiagnosis, and this is really important. Here is 2 patterns of swallows. So there's aperistalsis up here, everyone will agree with that, and this is ineffective esophageal motility, over 6 centimeters, 8 centimeters of contractile break here in all of them. However, this in fact is me. And I assure you, I can have an entire tomahawk steak in under 10 minutes, washed down by just a little bit of bourbon here. And when you do a solid swallow on me, my esophagus wakes up, with solid swallows and with free drinking. Unfortunately, this is not with bourbon, but I'm going to do that later. So at one point in the Chicago 3 is really important and still carries weight, and that is they say that the clinical significance of minor motility disorders continues to be actively debated. It was a strong feeling of the working group that overly classifying these was counterproductive as it distracted attention from the importance of identifying the major disorders. That was probably your statement, wasn't it, John? Or, yeah. I think it is. And it's true. I mean, look, these are water swallows, and these are what happens with many of the patients who receive that have absent peristalsis. You give them solids, and the esophagus wakes up. These are not images because they're unusual. We find this every week in our physiology lab. All our patients receive solids, a meal, and the change in diagnosis is absolutely clear. On the other hand, there's a problem of underdiagnosis. Here's a patient with aperistalsis and normal IRP. So this is a scleroderma esophagus. But then you give them a free drinking, and you give them a solid, and you see it's clearly an achalasia. And this patient progresses to having achalasia-type therapy. So it's absolutely crucial that we look further, and we don't just stop at one point. And we've shown this. Santosh and I have published this with Sabine and others. And we showed that we identified 29 patients who had normal IRP and aperistalsis, and the achalasia and the obstruction was clearly evident with provocative testing. And all of these patients had achalasia-style therapy, and the outcomes were exactly the same as those who had 5 ml water swallows with obstruction evident. It's not just in these cohorts. You also have spasm that can be elicited when you eat compared to IEM with 5 ml of water, as well as esophagogastric junction outlet obstruction. So these are all relevant. So what are the clinical implications? The association of esophageal IEM with symptoms is controversial and confusing. The observational studies report no difference in the proportions of symptoms. You know, heartburn, regurgitation, dysphagia, chest pain, belching. It's difficult to determine in patients with and without IEM. And the perception of dysphagia is not clear in IEM. We also know that, and we've heard this already, that up to 20% of asymptomatic healthy subjects have IEM. And up to a third of patients with normal endoscopy with dysphagia have IEM. And we also know from the Chicago group that IEM commonly does not impact on the quality of life and does not progress over time. In fact, a lot of these patients have no symptoms. While, on the other hand, the St. Louis group have shown us that the absence of contraction reserve in IEM can be associated with a higher risk of post-operative dysphagia. But there's also studies that show that post-operatively, those who have IEM can have an improvement and even resolution in their peristaltic dysfunction. And we have no therapy for this. There is no treatments that are proven clinically on trials to help patients with IEM or improve their motility. So, my final slide, clinical implications of IEM and provocative testing. I think what we need to come down to is how do we reduce overdiagnosis and how do we reduce underdiagnosis? Reduce overdiagnosis by giving the patient the benefit as much as possible to prove that their motility is normal. Peristalsis or what have you. Give them, chase the symptom, chase the problem. Water swallows, MRS, free drinking, solids, whatever you can to prove to the patient as much as possible that they are normal. On the other hand, we want to reduce underdiagnosis. We also don't want to be missing the obstruction, missing the spasm, missing the problem. And so we want to chase the symptom and try and elicit the problem. And whatever you do, MRS or solids, try to prove as much as possible that this patient has the problem or doesn't. Thank you.
So we can take a couple of questions.
Can I just say one more thing with regards to this? We've all received an email with regards to a survey of how you work in your labs. Please, everyone, answer these questions because this is really important to try and establish how things have progressed over time. We've done this study already way back in 2018, and we'd like to see how things have changed. This is a QR code. Take a picture of it if you want, and it's in your emails.
I shall send the email out again.
Rami, great talk. I'll take the liberty of asking a question. I totally agree with you. I think the diagnosis of IM has really, been overdiagnosed, and really what you need to do if you really want to see if the esophagus is effective is to stress it. And that can be done with, a solid test meal or even a flip. I mean, flip is a stress test of the esophagus. The one thing, though, that, I think we've lost a little bit of sight when we think about at least physiology and motility is, there's a difference between failing to trigger a swallow and then a swallow that actually is weak or, associated with atrophic muscle, right? And one of the things we tried to do in Chicago was get to this frequent failed versus a real weak muscle, to try to kind of get at the etiology. And I think, we've lost that, there are some patients who just don't trigger a swallow in a peristaltic wave, but then when you give them a meal, they have either secondary peristalsis that looks beautiful and normal. So do you think we should in any way go back to looking at mechanisms of neurogenic and myogenic function, or do you think it's all just bullshit?
I don't think it's bullshit. No, I think you're absolutely right. And I think you guys are showing some of this with your endoflip work, with your primary peristalsis, secondary peristalsis work, whether it's something if there is a myogenic problem or neurogenic problem. And I think regardless of what we're doing, we need the most important thing to do is to try and prove normal where possible. And then where it's abnormal, then we can go back and see how can we trigger this in some way or another? Is it with a with endoflip? Is it with a drug, or is it with what have you? And we need to think that as the previous talk has suggested, if the patient has no symptoms, we don't need to keep investigating. You know, the patient doesn't come to you with dysphagia or comes to you with something completely separate, like throat clearing, and you find IAM. So what? Why do we have to keep pushing and pushing? This might be just a variant of their normal.
I mean, yeah, I mean, surgeons have shown us that, you know, dysphagia, the symptom of dysphagia is really what drives postoperative dysphagia. So you scope someone and they don't have achalasia, which you can rule out with an endoscopy a good portion of the time, and they don't have dysphagia. I know this is going to seem like blasphemous, but they don't need a manometry.
Any other one more question that we can take?
I actually significantly disagree with that. My clinic is absolutely full of people with post-reflux surgery dysphagia who have normal endoscopy but clear evidence of symptomatic obstruction on testing. And the thing is, if you don't use bread or a realistic meal, you will miss this.
But those people had dysphagia probably before the actual.
No.
Yes.
No, absolutely not. No.
And their endoscopy looks like
they had cough and stupid symptoms that probably shouldn't have been. I mean, if you
someone presented with cough with dysphagia with a normal endoscopy.
If you don't have reflux before the operation, then you probably shouldn't have an operation. You know,
Yes.
But there's a complex interaction of psychological and other things going on here. I completely accept. But if you do
a good endoscopy and they don't have dysphagia, the risk of having achalasia is like 0.
Oh, if they. Oh, okay. Oh, sorry. Okay.
And they're not going to get. They're not going to get
like that.
dysphagia.
I'm happy to.
I
hear
mean, most
that.
dysphagia post-operatively is due to the operation. It's not due to what was going on before. That's a fallacy. That it's something that was going on before that we missed. That now all of a sudden became unmasked.
Okay, I misunderstood your point. Okay.
Okay. The last question. Yes. Everybody clap. Yes. Yeah, the last question. We have one.
I'm Marcin Banasiuk from Poland. I'm a pediatric GI. So I refer to the movies you've shown. Try to put yourself in our shoes. We are investigating these kids. But as a matter of fact, the question is... Absolutely. But as a matter of fact, do you quantify the DCIs of these provocative testing swallows, and how do you choose them? Because I guess that not all of them are perfectly seen. So not all, I know, bread or something is producing a pretty nice looking pattern of a higher DCI than before. So how do you choose out of them? Because IEM relies on the percentages.
So there are two ways of doing this. Number one, is the patient having symptoms at the time that this is happening? If they have no symptoms, then there's no need to sit there and measure every single one. On the other hand, if there are symptoms, what you can do is you can measure the DCI of the swallows, because there will be measurable.
I mean, IRP as well.
We're not talking about DCI rather, and you can determine from those which are relevant and which symptoms are contributing. And when you add impedance, you can see it clearly.
Okay.
That's what we like. That's what we like in pediatrics. We like in
I think let's close discussion here, and this is the last one, Santosh, and then this one.
That's why we like
We'll have
impedance in
to-
pediatrics, because we see the kind of a validation of this pattern. Still, even though we are observing IEM quite often, I suppose, in pediatrics.
We can
despite
finish this over
picture.
bourbon later.
Yes. Okay.
Never wrap Rami.
Yes. Thank you, Rami. And our last didactic talk of the day is by Santosh Sanagapalli from Sydney, Australia. And he's going to tell us a little more than what Rami told us. That's the impact of position and provocative testing.
Thank you very much for the invitation to speak. And these are my disclosures. So look, everyone talks a lot about work-life balance these days. And one of the great things I love about living in Sydney is that we have great beaches. And this is the beach just down the road from my house, actually. And it's a great place to sit down, relax, unwind. But I must admit, sometimes I'm not very good at relaxing and I find my mind drifting back to work. And so when I see a lady lying back drinking like this, I think, hey, she almost looks like she's about to have manometry performed in the supine position. Anyway, I also had a baby earlier this year, And in the hospital, I was really surprised to see the midwife asking us to feed him with a teaspoon. And it's terrible, I know, but I always thinking about work. So I started thinking, hey, how cute, it's his first 5 ml water swallow. Sad, I know. Anyway, the purpose of that digression was to acknowledge that, yes, there are a few situations in life where we drink supine or drink 5 ml at a time, but I think you'll agree these are few and far between, which is problematic because the whole point of manometry is to determine what's causing the patient's symptoms when they're eating and drinking regular liquid and food. So I think you'll all agree that testing with larger volumes of fluid or food is intuitive, but it's not enough for something to just be intuitive. We also have to know, does this actually change the findings of esophageal testing? And more importantly, does it affect the way we manage our patients? And most importantly, does it actually help them? And that'll be the focus of my talk today. So I know I've heard a lot about provocative testing already, but I'll just be really focusing on the evidence showing its actual clinical impact for your patients. So firstly, in achalasia, we have already heard a bit that the main issue with 5 ml water swallows in diagnosing achalasia is that it just doesn't pick up some cases. The IRP isn't raised because you can't, I guess the 5 ml of water can't pick up that esophagogastric gradient. But we can uncover outflow obstruction with provocative testing. And you can see an example here. It was a classical clinical syndrome of achalasia, normal IRP but aperistalsis. When we give solids, suddenly panesophageal pressurization is obvious, as well as the raised IRP. And a very similar case here, different patient, but same thing, the raised IRP and pressurization was picked up with the rapid drink challenge. And we did here already, but we actually reported on a cohort of such so-called normal IRP achalasia cases, and we actually, I guess, compared them to standard achalasia. So they comprised about 8% of the total cohort of achalasia, and when we looked at their therapeutic outcomes, we, I guess, validated the diagnosis by showing they respond just as well as those cases of achalasia diagnosed traditionally. So I think it's fair to say that adding provocative testing here increases the yield of actual clinically relevant diagnosis that will respond well to therapy. Provocative testing can also change the subtype of achalasia. So this is data presented by Rami's group at UEGW last year, showing that in almost half of patients with achalasia, the subtype changes from water swallows to provocative testing. And mostly this is type 1 changing to type 2 when you fill up the esophagus with food or fluid. But actually, like in this case, there were several cases where type 2 became type 3. And this may have some clinical implications for their prognosis and how you treat them. We also know rapid drink challenge in particular can be a good tool and even substitute for the role of time barium swallow in monitoring the therapeutic response after you treat them. And in this study, it was demonstrated that a IRP on the rapid drink challenge of less than 10 correlated very strongly with a time barium swallow showing clearance. So it could potentially substitute for time barium in this regard. Now, I've also already heard a lot about how supine 5 ml swallows are, I guess, not very good at diagnosing EGJ outflow obstruction. We don't know the significance of the diagnosis when we do it this way. And I think both positioning and provocative testing can really help us here. So we know that a small proportion of cases of supine outflow obstruction will normalize when you put them upright. And like in this image here, these tend to be spurious cases. Their barium swallow shows normal findings, basically. However, if they're upright, then they're a bit more likely to have significant disease and barium retention. So you can see that you don't miss any cases by mandating that you diagnose it only when upright. The sensitivity is 98%, but actually the specificity is still very low. So it's an easy, simple technique to put them upright. It should always be done if you're starting your study supine, but it's important to remember that even when it's upright, the majority of cases that you diagnose will be spurious. And we heard about also in Chicago for mandating that we do some other testing. And I wanted to briefly talk about time barium here. So I think it's fair to say that if you have a positive time barium in EGJ outflow obstruction, it's very highly predictive of true outflow obstruction, and you can be confident that they should respond to LES disrupting therapies. However, it's also at the same time true that time barium is rarely positive in EGJ outflow obstruction, and even when it is positive, the amount of barium retention is very low. And there have been a few series that have demonstrated this, but this is just our data, and you can see in the yellow columns, there is significantly less retention of barium in EGJ outflow obstruction for both height and width at all the time intervals. And important to note that in this study, we only included symptomatic EGJ outflow obstruction, so their Eckhart scores were exactly the equivalent to all the 3 achalasia subtypes. So it raises the question, is time barium swallow less positive in EGJ outflow obstruction because it's a less severe condition, or is time barium swallow actually missing cases? In our institution, we've been routinely performing provocative testing with solid test meal for a long time for cases of EGJ outflow obstruction. And what we noticed is that in some cases, you not only see confirmation of the raised IRP on the solid meal, but you also see changes in the esophageal body with abnormal pressurization patterns like seen here, and sometimes also abnormal peristaltic patterns. And we hypothesized that maybe it's these patients who have these abnormal patterns in the esophageal body during the test meal that represent true outflow obstruction. So a couple of years ago, we reported on 121 consecutive cases of EGJ outflow obstruction. And in this study, we included everyone with some intact peristalsis and raised IRP on any test, whether it was 5 mL of water or the provocative tests, according to the specified cutoff criteria. And you'll see here that there were a few cases that were only diagnosed with 5 mL of water, and these tended to be very minimally symptomatic cases and generally got better without any therapy, whereas there was a significant number of patients who were only diagnosed with the provocative testing. At that stage, anyone who had structural causes of EGJ outflow obstruction excluded with endoscopy and were symptomatic were offered achalasia-type therapies. And so we actually, in this study, used their therapeutic outcomes to basically evaluate the performance of the diagnostic tests. And we considered someone who responded to achalasia therapy as to be a pretty good marker of having true outflow obstruction, whereas someone who got better without any treatment at all, we thought that was a pretty good marker of being a spurious case and not having outflow obstruction. And basically using these definitions, we found that the sensitivity of provocative testing, and particularly the findings of dysmotility and pressurization during provocative testing, to have very high sensitivity for picking up cases of true outflow obstruction. And this was significantly higher than the sensitivity of both 5 mL swallows and time barium swallow. So important finding was that time barium swallow actually missed almost half the cases of true outflow obstruction. However, the specificity between the 3 modalities was quite good and similar for all. So again, this corroborates the previous data that when you do have a positive time barium swallow, it is very accurate in predicting true outflow obstruction. So I think it's fair to say that positioning and provocative testing have a really important role in clarifying the diagnosis of EGJ outflow obstruction, and in some ways, the data presented here show that it can be even superior to radiology. So we've heard a lot about hypomotility already, so I'll try not to repeat this too much, but suffice to say that the MRS is probably the most well-established provocative test in evaluating hypomotility, and if we see augmentation on the MRS, then that's a reassuring finding. As Rami mentioned, you can also do a similar thing with the solid meal, and quite frequently you'll see completely aperistalsis or even or ineffective esophageal motility completely normalized when you administer the solid meal. And I suppose the main clinical implication of provocative testing is in the prediction of postoperative dysphagia, as we've heard. And if you see an augmented MRS in your pre-op manometry, then you can, I suppose, in a way, reassure the patient and your surgeon that the likelihood of postoperative dysphagia is going to be very low. What about spasm and hypercontractility? So the issue here is that they have as we've heard, they have a very heterogeneous disease course, heterogeneous presentation, and it's sometimes hard to know what to do with these patients. And provocative testing can help us in some ways. Firstly, you may feel more comfortable treating these patients if you find on their provocative testing that they reproduce their symptoms in combination or in conjunction with the manometric abnormality. Then you may feel that this is more likely to represent clinically relevant disease. However, I must say that there isn't a lot of data supporting this assertion at the time being. This is, I suppose, just intuitive. Perhaps even more importantly, the rapid drink challenge, but especially the solid test meal, might actually unmask subtle LES obstruction that wasn't seen with the 5 ml water swallows. And in a sense, you upstage these patients to a more significant disorder, but in some ways, disorders with more established treatment paradigms. And this is an example of a patient we had, which was basically met the criteria for hypercontractility on 5 ml water swallows, with at more than 50% having a raised DCI of 12,000, but normal IRP. When we gave the test meal, suddenly we not only confirmed hypercontractility with DCI up to 26,000, but we also saw premature contractions and a markedly raised IRP. So you're now dealing with, if not type 3 achalasia, then possibly at least EGJ outflow obstruction. So the main utility, I think, of provocative testing here is that you could potentially reclassify the disorder into a more compelling therapeutic target of the LES. What about so-called normal motility? Well, the issue here is that often when you do HRM with water swallows, you don't actually identify any cause for the patient's symptoms. And the question is this because they don't have a motor abnormality to account for their symptoms, or are we missing cases of motor dysfunction with 5 ml swallows? And I think by reproducing symptoms, we can increase the diagnostic yield of HRM with provocative testing. So I guess taking it back to first principles, we know that most patient complaints are with solid food ingestion, so it's very unsurprising that HRM with water swallows rarely provokes symptoms. And I guess from an even more philosophical point of view, you have to ask, can a HRM study perform without food and therefore without producing their regular symptoms? Can you really use that to definitively rule out a motor disorder? So this is just one example, hopefully illustrating this point. And you can see on the left, this was a patient with dysphagia. Her 5 ml swallows, I think there's nothing much to see there, and certainly not meeting the criteria for any motor abnormality according to Chicago. Suddenly, when we give her the test meal, she tells us she's having her typical dysphagia symptoms, and we see there a markedly raised IRP with outflow obstruction and a reduced distal latency and a spastic type contraction. And I know this paper's been presented a few times already, but just drilling down on this, I guess, aspect of so-called normal motility. So this was a cohort of 750 patients who had sequential investigation with both single water swallows as well as a solid test meal. And firstly, the test sensitivity for picking up major motor disorders was almost double for the solid test meal compared to water swallows. And importantly, going against the fact that you're not just picking up false positive diagnoses, this was predominantly in patients presenting with dysphagia. And if you have a look at the table here, we see out of the cohort there's almost 150 patients, or even more, of the total of 750 who had relatively minor disorders of either completely normal or ineffective esophageal motility on single water swallows, and ended up having either spasm or EGJ outflow obstruction on the solid meal. As expected, the likelihood of reproducing the patient's symptoms was significantly higher with solid meal compared to water swallows. And I thought also of interest, there were 89 patients in this cohort who did reproduce their symptoms on the solid meal and had normal motility. So for want of a better word, I've said that maybe we can really call these true functional dysphagia. But what I mean by that is I think in these patients, you've more truly established that there's no motor disorder accounting for their symptoms because you've showed normal motility at the time of their symptoms. So I think the clinical impact of provocative testing, and in particular the solid test meal, is that it can more definitively confirm normal motility in your patients. So what about incorporating this into your practice? So I think we should acknowledge some barriers to doing so. There is definitely some added time for testing, very little for MRS or rapid drink, but the solid test meal, depending on the patient, may take up to 8 minutes. I think it's also fair to acknowledge that it is a little more difficult and time-consuming to analyze. I think especially the solid test meal. I think there's no way around this, and it's true. But I would say with time, I think the speed of analysis and the ease of analysis certainly gets quicker, and I think it makes for a more satisfying reporting experience, in my view. What about which provocative test to use? Because I've presented several. Well, certainly one option is to do a directed approach to provocative testing, depending on your findings during the small volume water swallows. Obviously, if you're not doing the testing yourself and you have a scientist or physiologist, then you're reliant on them to be up to speed and be able to make that spot diagnosis to direct the provocative testing. However, you'll notice from this table that for almost every indication, solids do work in, I guess, identifying or dealing with the weaknesses of small volume water swallows. So, of course, the alternative is to just have a routine approach for all comers. At our institution, we do the rapid drink challenge and solid meal in every patient. Thank you.
So we're a little bit behind. What we're going to do is Shobna and I are going to yield the chair to Mark and Rena, and you can relax. Very good talk. And we'll let them take on the questions focused on the protocol, because I'm sure people have many.
Thank you, Joan.
Thank you, John. Thank you, Shobna. Okay, so this part of the afternoon is more of an open discussion. We do have cases that we could discuss, but we've seen a lot of examples, and we're very happy just to take questions and direct the answers to different people in the audience or to ourselves, depending on what's being asked. I will take it as it comes, and if we need the cases to back up our points, then that's what we'll do. But please, Jenny, you've been waiting for this.
Thank you, Mark, and thank you, everyone. I think all the talks today have been absolutely fantastic. And Jenny Myers, Adelaide, Australia. I'm just sort of trying to link between the symptoms that we're evaluating and the sort of diagnostic tools we've got, particularly the provocative testing within manometry, because I think that's probably a sort of common test that we've all got available to us. Should we be trying to limit how many provocative tests we do? Should we start with a symptom cutoff, for instance, like say the Eckhart score of more than 3 to select particular provocative tests? And I just wondered whether there was some comments about that, particularly the solid meal, which takes longer.
Yeah.
Okay, I guess I'll start. So I do think that so symptom severity in many studies and in many settings is as much to do with patient psychological situation as it is to the motor disorder. So whatever's wrong with us, if we're stressed, if we're anxious, if we're depressed, our symptom burden is higher. And it's very unfortunate for the uncomplaining but genuinely unwell if we make cut-offs of that kind, because we'll often then be focusing on exactly the people who are simply nervous and not actually unwell. I mean, we all know the old achalasic who's been regurgitating onto a bed pillow for years and years and just refuses to say that she's got swallowing problems because, well, she doesn't express her problem in that way. So that would be my response. Do you have a...
Yeah, sure. So, we talked a lot in the last iteration about the protocol, right? In general, even though many labs are doing it differently, in general, the practice was 10 wet swallows. And there was a lot of concern with even adding on an alternate position. We talked about more swallows in an alternate position, MRS, rapid drink challenge, solid tests, and there was a lot of concern about the actual practicality of it, the time. We heard in the last talk about, some of the time constraints. So I think you bring up a really good point, and, we had also said, can we individualize it? And this was brought up in the last talk also. Depending on what you see with the first 10 swallows, then can we decide that someone needs a solid test meal versus something else? But again, that's not... within the license of everyone that's performing the manometry. So, I actually think what you said is very interesting. I mean, if we can develop some kind of risk stratification model before we perform the manometry that can be protocolized, I think it's very intriguing. I just haven't heard that done before.
Right. Could we have the... sorry.
Yisharon from Tel Aviv.
Yes.
I would like to watch your opinion of the timed barium swallow for patients with EGJ-00. Would you recommend adding as a protocol the tablet or just the liquid phase?
Yes.
Well, yes. I mean, we routinely. I mean, one has to generate a good working relationship with one's radiology department, because there aren't many that are very interested or particularly skilled at doing GI measurements, and it's the kind of thing that's given to the junior assistant who'll look up a book and do it like it says there. But I give detailed instructions, and we have good relationships, and we pick up a lot more with when the solids are used, tablets, or there are, of course, other solids that are used.
Agree. Liquid for achalasia, there's good correlation, but that tablet for EGJ outflow obstruction has been shown to have a higher diagnostic yield. So absolutely.
Yeah.
I'm not actually, it is working. Rebecca Burgell, Melbourne, Australia. Do you think there's going to be a time where we just do the provocation tests? We are testing function here, and very few people eat lying down and with 5 mil.
Well, so
the thing we care about is how they eat.
Well, okay, let's have a vote. Okay, so we'll do it in 2 different ways. Who does supine water swallows? Who doesn't do supine water swallows routinely? I'm not talking about studies here. Who does upright water swallows? Who does no water swallows at all anymore because they just can't be bothered? Okay. Who does the multiple repeated swallow at least 3 times? No, okay, at least 2 times. Who does the rapid drink challenge at least once? And who does single solids swallows but not the test meal? And who does the solid test meal almost always? I mean, not if you get achalasia with the first.
This is very similar to the survey we did before we started 4.0.
This is the whole point of the survey we're doing now.
But who would disagree with the statement? These people have waited 3 months for a manometry. They've had symptoms for 5 years, and I'm going to waste 8 minutes doing a test meal? So this, I feel, is very difficult to sustain. And I think that I think we should, it's not that I think everyone should do a test meal all the time. I think you should do tests sequentially until you either have an answer or you really feel that you've ruled out what you're looking for.
So exactly what we were saying before, chase the symptom.
Directly in Rami.
You need to chase the symptom, change the problem. If the patient has dysphagia when eating a burger, bring a burger. Rather than test with small volumes of water and say, it's normal, so that must be when he eats a burger, he's fine. But you haven't tested the problem.
Rami, I have a question about that. How do we standardize things to have normative data? Because in clinical, we can look at patterns, but in clinical practice, if patients are bringing in different types of meals, how do we standardize it?
Well, I mean, we did do 75 or 6 normal volunteers eating a 200-gram softly boiled rice meal. I mean, that's exactly the same standard as we've got for water swallows.
Yeah. And you also did cheese it
in a burger.
Well,
I know. Okay, but no, we've tested. No, but we did actually test that. So we've recently published that we have very little difference, no significant difference at all between when patients bring in the provocative meal that they feel is a problem and using our standard rice or indeed bread meal. So any soft, solid meal gives indistinguishably similar results. It doesn't seem to be super important, but symbolically to the patient, it can make a big difference. So take your patients seriously if they say, when I eat an apple, I've got a problem, bring them an apple. You know?
Exactly. So what we do is we give everyone the boiled rice, which is what is the protocol and the validated tests that were published. And then on top of that, we ask them to bring their meal, because you could elicit the problem as well. Now,
but not all of them do it, do they?
Not all of them do,
No.
because they're you know, but nevertheless. But to come back to one of the points before, there is also an important point that patients adapt over time. So if we are going to just wait to see what their ECART score is, they might have adapted their eating behavior over the last several years, such that they're not eliciting enough of a symptom burden for you to have that cutoff. And so when you then change their behavior to eat something that they normally don't, such as rice, if they try to avoid rice and have a liquid diet primarily, then you are eliciting something that you would have not been able to see. If you do 5 ml water swallows, you're going to miss it.
So just to put some statistics on that, in our study of 750 people, 20% of achalasics had no dysphagia.
Yeah.
I mean, they did. They ate really slowly.
Yeah, eosinophilic esophagitis is the same. And to come back to your question about barium, we've we've published, Santosh and I, how the high specificity and sensitivity to picking up patients who have obstruction is not just with a 5 ml water swallow at the end, but the change in the surface area or the change in column height pre and post achalasia therapy. And those are that is the highest, the best way to determine outcome, and rather than just have a standard barium.
Rami, can we give your gelato to pair?
The message for your protocol. My message is that you can standardize what is your solid food. Texture of food is a combination of 3 properties: hardness, adhesiveness, and cohesiveness, and you can measure that, and food industry does.
So in the pharyngeal swallow, we also use viscous swallows, and we're very careful about these. So, okay, yeah. I mean, these factors, what we're talking about now, are even more important in the pharynx than they are in the esophagus.
So,
yes.
Enrique Cos from Mexico, and I think that this mixer that we have in the opinions to do, I think, in the supine or in the upright position, and if we do all the protocol all the way, I think that it will last more than my trip from Mexico to here. And so I will like you to say who is performing the esophageal manometry in your site. I mean, if there is a doctor who is performing the manometry, then they can ask the patient what is the main problem, so they can perform all this series of provocative tests. But if it's a busy practice and they are coming like 20 persons per day to do an esophageal manometry, is no way to perform the long protocol. So
eight minutes. 8 minutes, Enrique.
No, but we do hear this a lot in practice. I agree.
But the judicity of who to perform each of these.
So this slight misunderstanding in the Chicago Protocol. There was never at a point where we said you have to do all of it all the time. For research purposes, one can argue that that might be appropriate, but it's very important when you're doing consensus studies, and as a veteran of very many such things, you have to keep an open tent. You know, you want the camels in the tent pissing out and not pissing on your tent. You know, if you have too many people who can't buy in to your consensus, you haven't got a consensus. And this whole field of research is taken so much more seriously now that we're all sitting here together and agreeing to disagree perhaps on certain points, but keeping our protocols open enough so that even people who really don't want to agree with what I'm saying can still use it. Mm-hmm. They might not use all of it, but we're all talking the same language. We're all using the same metrics. We might not be doing it exactly the same way, but it's similar enough so that when you produce work in Mexico, I can understand it in Switzerland, Rena can understand it in San Diego. This is the point. And I mean, as has been implied, in the clinical practice, upright swallows, water, solid test meal, rapid drink challenge, solid test meal, 8 minutes, done.
So a quick question, or actually more statement, I guess. So we've been doing the same protocol for like 15 years. which is basically everything that's been discussed. And we do ask people to bring in a meal that gives them symptoms. And I do think it's important. I think it does pick up patients who sometimes would look either like they have IEM or normal, and you pick up abnormalities. My only point with the meal test, and this is something that I've struggled with, is honestly, it's very difficult to tell whether someone has achalasia, a mechanical EGJ outflow obstruction, a spastic response to food just sitting in the esophagus. Those patterns look very difficult to distinguish in terms of disease state. So I think the way I use it, and I do think it's important to incorporate, is that if it's normal and looks fine, perfect, just like we saw in that last talk, I agree perfectly, that person's probably pretty normal. But when I see these patterns, it's very difficult for me, that's achalasia. Oh, that's a mechanical obstruction that was missed, unless I've done the endoscopy.
But you've got the water swallows already. If it's a classic achalasia, you're already pretty sure that something's not good, even if it's the IRPs.
So the point is that you're not really, when you're seeing those patients, you're picking up a mechanical obstruction most of the time that was missed, right?
That's right.
And it gets back to the point, I scope everyone, and I do the endoscopy. If you don't trust the endoscopy, then you will miss those people. But I've seen these people, they come back, they've got a positive test. I scope them, and it's clearly EOE that was missed by somebody else. Wow. It is clearly a stricture that was missed by somebody else. So I do think if you're doing this blinded and you have not done the endoscopy, and you're doing this open, then the test meal and solid swallows are a must. Similarly, I would ask the question, how many people in the audience watch people eat in their clinic? Do they watch them drink water and eat a piece of bread or a cracker? How many people do that?
Well, I mean, I do it during the manometry.
Well, yeah, but I mean, even during clinic though, because, you know, when you watch people and you watch them eat, I mean, that should inform your diagnostic decisions. If you see someone who comes in and tells you they're dying every time they're eating, and you watch them eat and they eat completely normal, you know, you start questioning things. So I just think there's a lot that you glean from your history and your endoscopy. Hence the talk tonight at 8 p.m. So if you want to hear more. But I do think we miss that opportunity. But certainly, I think it's crazy to not think that solid food or giving solid food during a manometry when you haven't done the endoscopy to rule something out like that is probably crazy now. I do think we need to do solid swallows, and we've been doing them for years, and you do pick up people that were obviously missed by other endoscopists who don't really care. They do a 10-second endoscopy, and they say, oh, I didn't see anything, and then they send them for a manometry. So, you know.
Well, amen to that.
Yeah. So 8 minutes, we do actually 30 minutes. We actually have the meet, and then we will actually watch them afterwards to see what happens. So, I mean, it's even more than that. And luckily, I don't do that. My motility tech does.
Okay, here's the next question. Who does the manometry themselves most of the time? Depends where I'm working.
Marcelo?
So a brief comment and then a question. It seems the solid swallows are able to uncover obstruction that may have been missed. And I think at least where I work, we often do that with the endoscopy or with a barium tablet. And
it will be missed on multiple occasions. All the studies, published studies, show that it's, I mean, not, of course, a good quality endoscopy should be the starting point. I don't want to see people in my manometry lab who haven't had an endoscopy.
Right, or a barium tablet, I think, works very well. Now, my question is, you know, there's very compelling and interesting data about the solid swallows, but more from a technical perspective. You know, when we do the liquid swallows, it's very controlled. We know what we're measuring, you know, during the meal, the patient's eating. So what part of the meal do you focus on? And if there's abnormality anywhere during the meal, do you consider that abnormal? You know, how do you standardize the reading? And beyond that, do you have any data on inter-rater and intra-rater also reproducibility for analysis of the solid portion?
We did that as part of the validation, yes. These were blindly read by multiple people, and the studies are very... as John said, frequently, even before you expand the data, you know what the diagnosis is. Lots of medicine is qualitative. You know, you don't need the biopsies to see it's a EOE. Sometimes you do, but sometimes you really don't. You know, it's obvious. And the same is true for manometry. The analysis, I was very tempted to try and focus on a part of a test meal in the way that you're suggesting. But we consciously did not do that because we wanted to make it hard. Like the whole part of the Chicago process was to make it hard, to really set hard thresholds, so that we were taken seriously for a change, back in 2007, 2008. And the same is true for solids. It's properly abnormal findings we're looking for. They're normally unmistakable and not hard to see. And if you combine it with impedance, you can see bolus transport, because to go, as Rami suggested, back to Radu and Don's work, it's only really when bolus transport fails as a consequence of motility disorders that the patients get symptoms. So you want to, you want to see that failure of bolus transport either directly using impedance or by inference seeing quite significantly abnormal manometry.
And with all of that in mind, what are the sort of kappa values for inter-rater, for conclusion, normal, abnormal?
Really high, 0.8 plus, really high. Yeah. What's lower is, at least the last time we tested, and this is something we want to repeat, is there is some in the realm of spasm, EGJ, OO, there is some difference between inter observer value. That's true, but it is not very high. And what's more important, I would argue, is a bit like when you're analyzing a pH impedance trace. The first thing I do is I focus on where the symptoms occurred. I mean, I do the full analysis, but I really look first at where they had the symptoms. And if every time before the symptom there's a nice reflux event, then I'm pretty happy with my diagnosis. And if there's every time before a symptom in the esophagus clear evidence of obstruction, then I'm pretty happy with that. And the reverse is also true.
So Prakash Gwali, I'm standing up because I'm asking on behalf of Sabine as well, who is over there.
Hi,
Because
Sabine.
I'm texting with her. This question is for Santosh. Would that be okay? Sometimes you have to think about what would you do if you had all the power in the world, right? Let's say you have the power to influence everyone in this room.